Again, I was asked to speak about diving in the era of COVID-19. This is my hospital there on the left and our clinic there on the right. One of the questions I'm sure most of you people are thinking is, who is this guy and why is he talking to us? Adele covered a little bit of this. So as you mentioned, my day job is I'm an interventional cardiologist, which some people would consider a frustrated cardiac surgeon, meaning that I do a lot of procedures. I basically go to work in my pajamas, and scrubs all day and look at a monitor, ultrasound and x-ray, and do stenting or close holes in the heart or replace valves through needle sticks or those types of procedures. So those kind of things I do on a day-to-day basis. Like she mentioned, I've been diving since 1974. I teach and dive recreationally, technically cave and rebreather. That's me getting ready for a cave dive there on the right. The combination of my background in physiology and cardiology, along with my diving background, I dive probably 100 to 120 dives a year, led to me, being a physician who actually dives and dives in a lot of different environments. That led me to becoming a cardiology consultant to the Divers Alert Network about 10 to 15 years ago. And then, like Adele mentioned, in my spare time, I'm also the Florida sales agent for KISS Rebreathers. But that's not really why I'm talking to you. That's not what's really important. The other aspect of this that is important is I'm also a COVID-19 survivor myself. This is my positive test with me sitting in my N95 mask several months ago. So back in late March, I was exposed to a patient in my office for a totally unrelated reason. He was coming in for an elective procedure, but appeared markedly short of breath. I admitted him right to the intensive care unit from my office. He was in the ICU for several days, luckily did not require intubation, and was hospitalized for about 3 weeks total. I developed symptoms about 10 days after I was exposed to him. That included typical flu-like stuff, fever at 102, non-productive cough, shaking chills, profound fatigue, and in fact, one day I was in bed for 17 hours. But got over most of that in about 3 or 4 days. Symptoms completely resolved in about 10 days. And this is important. I thought I was back to normal, and people who have this illness all of a sudden begin to feel like they're back to normal. But the gyms were closed back then, so I wasn't able to go to the gym, which I normally do several days a week. So I broke out my home rowing machine, which I can usually do 30 or 45 minutes on, and I was about 10 minutes into it, and I was totally gassed. So while I thought I was back to normal, my lungs had not recovered yet. It took about 2 weeks for that to completely recover. And I put myself on a treadmill at work after one of my office days with a pulse ox and jogged on the treadmill for a few minutes and made sure my oxygen saturation was okay. And then that led to the most important part of things, which is I returned to diving a couple of months ago. I was out of the water for about a month and a half with all of this, and then returned to diving. This is some pictures I took my first dive back. So that's me and my dive buddy in the left upper corner. This is how they spread things out in the dive boat. This is back in May, so there's only 8 divers allowed on the boat, just like kind of how we spread everything out. And these are just some photos I took from that first dive back. Shameless plug for my favorite operator in West Palm Beach, which is Pura Vida, and so forth. Okay, so that's kind of the setup as to kind of why I'm talking about this, and obviously we're all very interested. So the way I've broken this talk down is we'll talk a little bit about the virus to make sure we're all on the same sheet of music, and then we'll talk about the implications of COVID-19 to the diving industry, those of us as divers and dive shops and dive charters and so forth. So the SARS-CoV-2 virus that we call COVID-19 is a coronavirus. It's called COVID-19 because it came about in 2019. Coronaviruses are ubiquitous. They're everywhere. These are spherical envelope positive strand RNA viruses. They commonly cause respiratory illnesses. They're all over the place. They cause about 15 to 30% of the common cold. But they have been some mutations in the past that were very severe. The two that were the most severe before the current pandemic was the SARS virus. That was the SARS-CoV-1 virus. And then the Middle Eastern virus, the MERS-CoV virus as well. The CoV-1 virus is the one we all heard about as SARS back in 2002, 2003. It pales in comparison to the numbers we're seeing now. But at the time, it was a large number of cases. It was 8,096 cases reported with 774 deaths with a mortality rate of 9.6%. The MERS virus was much more deadly. fewer cases. It only had about 2,500 cases back in 2012. It was thankfully not very infectious, and we'll talk about that in a couple of slides, because its mortality rate was 34%. So if this had spread like our current virus, we would definitely be in a world of hurt. The current virus, I think most of us know this by now, but what happened was there was a cluster of pneumonia cases reported to the World Health Organization on December 3rd, 2019. WHO then investigated, and they found a common exposure to a local seafood and animal market in Wuhan City, China. They isolated this virus and termed it to be the SARS-CoV-2, the genetic sequence of which is very similar to bat coronaviruses. That's where this whole thing about bats came about, and we were hearing about this back in March. And it's obviously been a worldwide problem. These are statistics as of about an hour and a half ago. I looked them up, and as of today, there's been over 18.6 million cases worldwide, with over 701,000 deaths worldwide. How's it spread? This has been debatable, and it's not that the experts don't know what they're doing in terms of how they define things and what the recommendations are. It's just as we gain more information and gain more data, the recommendations and so forth change. Current thinking is this is spread mainly by large respiratory droplets, so things like coughing, sneezing, speaking are the ways this is spread. It can be spread by what are called fomites from contaminated surfaces. That's felt to be a very minor thing. We don't need to be taking our boxes from Amazon and sticking them in the garage for 3 or 4 days like people were doing back in March and April, but do need to wipe things down just to be extra cautious. The airborne route is possible with an aerosol generating procedures. This happens a lot in the hospital. So for me, if we're intubating a patient or doing any kind of endoscopic procedures, transesophageal echo or upper and lower upper endoscopies, that can be a very risky procedure. For all those procedures, we get 1 hour COVID-19 tests on the patients before that procedure is performed, and we look like we're out of some sort of a movie. We have gowns, gloves, face protections, filtered masks, the whole 9 yards. And then actually when we intubate someone, when anesthesia intubates someone, they're the only one in the room at the time. We then have to wait 6 minutes. It's felt that these airborne aerosol generating procedures can stay airborne for about 6 minutes. So no one else comes in the room for 6 minutes. And then once things have settled, then we go in and actually start our procedure. So this is kind of how my days have changed over the last several months. The pathogenesis, we're learning more and more about this every single day. Basically, this is mainly a respiratory illness, and it infects the airways and the alveoli. Those are little air sacs that we all learn about in dive class when you worry about overexpansion injuries. These are little alveoli that can rupture and cause problems. This virus you see there on the cartoon on the right, the SARS-CoV-2 virus, comes into the alveoli. The alveolar macrophages try to fight this, and in most people fight it off. And those people either remain completely asymptomatic or have very mild symptoms. The problem is, and this is what we hear about, is in some people, you get this very inflammatory response with an activation of what's called a cytokine storm. And with that, you get what looks like an adult respiratory distress syndrome, kind of an ARDS, widespread pneumonia, very severe hypoxemia, and the illness can then spread to other organ systems, either directly or indirectly, and cause lots of problems. This is an example from our hospital. Trust me, the x-ray on the left is normal. This is a patient he came in with symptoms compatible with COVID-19. You'll see his x-ray, the black fields of the lungs there, they look relatively clear. The white markings are normal lung markings. You will see that this patient would be considered at increased risk. Those circles of wire that are going down the midline are his sternal wires from his prior bypass surgery. And that little elliptical object in the left upper chest there is a pacemaker with a pacemaker wire going into his heart. So he would be an increased risk. And this is his x-ray the following day. So on the right-hand side. So within 24 hours, his x-ray went to those black kind of normal looking lungs to patchy white infiltrates everywhere. And also if you look at those little circular wires I was talking about, right above them now is a vertical bright line. That's actually his endotracheal tube. So he actually ended up being intubated within 24 hours of admission. Thankfully, this gentleman did survive, but had a very prolonged hospitalization. You can also look at CAT scans. I'm going to show you this because there's a report I'll be talking about in a few minutes that came out of Austria about CAT scan findings in scuba divers. So I thought I'd just show you some pictures. This is a normal CAT scan of the chest here on the left. Again, the dark fields are the lungs. The little small areas of white are the blood vessels. If you look at the panels there on the right, the top three are kind of slices like the one you see on the left, but you'll see a lot more white patchy infiltrates. That's kind of what the classic look for these findings are with COVID-19, this very multi-lobar pneumonia where it's affecting multiple parts of the lungs. And then the bottom three panels are just other projections, side projections on the far left and far right. And then the one E there in the middle is like a straight looking chest X-ray like I just shown you on the previous slide. And again, I think you get the feeling all these white patchy infiltrates, that's the virus that's spread throughout the lungs. The timeline, the incubation period, which is a period where someone is infected but not having any symptoms, the mean is about 5 days, but can range anywhere from 2 to 10 days. Like I mentioned, I developed symptoms at about 10 days. This is important because this is the people we worry about infecting people without knowing it. You know, if you're sick and feeling bad, it's much easier to quarantine and stay away from other people. However, if you've been infected but don't know it during this incubation period, you can affect a lot of other people inadvertently. Initially, the most common symptoms are fever, cough, and shortness of breath. Though people do have GI symptoms, a lot of people have loss of taste and smell. If you start getting rapid breathing, that's when, and significant shortness of breath, those are the people that should seek medical attention. If you're just having fever, cough, fatigue, like you're having the flu, that can definitely be managed at home. You basically just stay home, you push fluids, rest like you would if you had the flu. But if you start developing significant breathing issues, that's when you need to seek medical attention. Respiratory failure, if it's going to occur, can usually occur around 7 to 10 days after symptom onset. That's when people get very, very sick and end up on ventilators. Like I mentioned, this is usually a respiratory illness, but over the last few months, we've realized it's having other effects outside of the lungs. It can affect the heart and form what's called a cardiomyopathy. I joke that we charge people by the letter, so we have to make sure things are long and complicated. What that basically just means is a weakened heart muscle. So if you look at there on the right upper panel, the normal heart is there on the left-hand side. Those arrows are the blood going out from the left ventricle out to the aorta. That's the size the ventricle should normally be. If you look at the right panel, you see how large the red area is. That's a dilated kind of, rather than look more like an ellipse, it starts looking more circular. The heart doesn't beat very efficiently in that kind of geometry. And that's what's called a dilated cardiomyopathy. And that also puts people at risk, not just for congestive heart failure from the weakened muscle, but also can set them up for life-threatening arrhythmias. So we know that can occur. Also, like with other viruses, this virus can cause what's called a hypercoagulable state. What that basically means is that your clotting system gets overly activated and you start putting clots in various places, such as in the brain, in the legs, in the lungs. And this is not unique to SARS or to the COVID-19. It also occurs in HIV, it occurs in dengue fever, and it occurs in Ebola. But when you get this, these are people that can form strokes. People can clot off their legs and lose their leg, like the Broadway actor that we probably all heard about on the news. It can also result in venous clots with DVTs in the legs, which can then progress to the lungs and cause pulmonary emboli. And we actually have we've had several people in the last couple of months when I've been on call or I've called in for a young person having a heart attack. We get them into the cardiac cath lab and their coronary vessels look perfectly normal, except there's a big chunk of clot that's closed off one of the vessels to their heart. So again, the same sort of thing where people don't have any underlying cholesterol kind of problems, but develop strokes or develop heart attacks just from the blood clotting abnormalities. Now, when this first came out, people said, oh, it's just the flu. You know, this is just like the flu. So I'm going to show you some data to show you this is not the flu. This is a bunch of different viruses. The x-axis there horizontally is what's called the R0 number. The more you go to the right, the more infectious something is. And then on the y-axis, the vertical axis is the mortality rate. So you can get an idea of all these different diseases that we deal with and kind of how infectious they are and then what the mortalities are. You'll see COVID-19 in orange and influenza there in kind of the yellowish kind of color. But if you blow that up in the upper right, the mortality from influenza is about 0.1%. The mortality for COVID, and we'll talk about this next couple of slides, the best we can estimate is going to be around 3 or 4%. So this is clearly not the flu. This is the comparison directly. So the R0 number, basically how infectious something is. This means how many people does someone who's infectious infect themselves. So the flu, everybody has a flu, will infect about 1.3 people. COVID-19, everybody except for these super infectors, most people will infect around 2 to 2.5 people. That's important because if we can get that number under 1, then that's when the disease dies out. So that's what we're trying to accomplish with things like wearing masks and social distancing and staying home and so forth, is that if we can get it down to a less than 1, then this disease will finally go away. Incubation times for the flu, a couple of days. For COVID-19, kind of usually around 5 days, but can range up to 10 to 14 days. Only about 2% of people with the flu end up in the hospital, where almost 20% of people with COVID-19 end up in the hospital. And again, the mortality rates are somewhere around 0.1% for the flu and as high as maybe 3.4% for COVID-19 based on the individual. This is just to show you that we don't really know for sure what the mortality rate is, because we don't know exactly how many people have the disease. We know how many people have been tested positive. We know how many people have died. And that will give you a particular number, but there may be a lot of other people that would be in the denominator of the number of cases that we don't know about, which would make the mortality rate much lower. So currently the rate is around 3.5%. Estimates are somewhere between 1 and 4% for mortality. And again, that's still going to be about 10 times higher than seasonal flu. This is what gets a lot of people worried. This is why I've had so many fatalities in Florida in the nursing homes. There's a very strong predictor of age and fatalities. It's very, very rare for people under the age of 40 to die from this disease. They can get very sick, and there have been people that died, but the rate is still quite low. But you see, as we start getting into older age groups, 50 to 60, 60 to 70, 70 to 80, and especially when you get over the age of 80, the mortality from this is very, very high. So that those people definitely should be staying indoors. They should definitely be sheltering in place and so forth to try and protect themselves. As far as infectivity, we talked about this idea that the R0 number is around 2 or 2.5. What does that mean? It's about as infectious as something like Ebola would be, or around the time of the flu. But if you start looking at things like measles, this is something that affects everybody that gets infected. Gets about 12 to 18 more people infected. Things like smallpox, polio, mumps, and so forth, around 5 or 7. So it's less infectious than those things, but still a concerning number. So what have we been doing in the United States? Well, we all know this because scuba diving is based on travel, and we can't go anywhere. So we live vicariously through all these great little vacations, but currently we're left with local diving. Thankfully for all of us, we live in Florida, so the local diving is outstanding. Our daughter, who is a rebreather instructor like myself, lives in Iowa, so she's not doing any diving at all. So she lives vicariously through my trips at the moment. Along with travel restrictions, there's case isolation, contact tracing, and quarantining people to try and keep the spread of the disease down. Obviously, we're trying to do social distancing. It's felt that the virus, at least with normal speaking, can probably only travel about 6 feet. And that's the idea of why we're trying to stay 6 feet apart. Things like singing in a church, so you're projecting your voice, it will travel much farther. So that's a little bit concerning. But in general, for day-to-day activities and just talking to people, about 6 feet. Coughing will send it farther. Singing will send it farther. Sneezing would send it farther. So just be aware of those things. And obviously, vaccines and therapies are under development. We can talk about that if people have questions. This is kind of how we're currently treating people in the hospital. I put this curve up to kind of reiterate the point that we know the cases are coming up again, and that's to be expected. This whole thing, I'm sure none of us ever want to hear the term flattening the curve ever again for the rest of our life. The concept behind flattening the curve was not to decrease the total case numbers. The same number of people are going to get infected, so we don't have a good treatment or a vaccine. The idea was to have them get infected over a longer period of time. The idea is we have certain limitations from a medical standpoint of how many people we can take care of. There's a limitation on ICU beds, there's a limitation on ventilators and so forth. So the idea was if we allowed, let's say the number of ventilators that we have would be the equivalent of like the top of that line that says social distancing flattens the curve. Well, if we had the red curve, we're going to get over this disease pretty quickly. Within a few months, it'll spike and come back to normal. However, there's going to be about a 1 month period of time there where we have far more people needing ventilators than we have ventilators. And what that's going to do is that would put physicians having to make very difficult decisions as to who gets put on a ventilator and potentially survives and who does not get put on a ventilator and will die. So the idea behind flattening the curve was to spread out the number of cases so that we don't overwhelm the medical system. So that's what that green curve is. It's kind of slightly, you see, it's going to have the same kind of area under the curve, but just be spread out. And then as we release and lift interventions, they allow people to go back to restaurants and allow people to go back to gyms and barbershops and hair salons and have more interaction, you're expecting you're going to get another bump in the curve like that blue, so that the same number of people probably get infected, but they get infected over 10 months or a year as opposed to over a month, and then we don't actually overwhelm the medical system. That was the plan, and that's kind of what's been going on. So that's the disease in general, but we're all divers. So the questions come up as, okay, how does this affect the diving industry? There are several questions that I wanted to pose. One that people ask is, well, can the virus be spread underwater? That's important to us. Number two, how do we appropriately disinfect our gear? Number three, how do we safely resume diving? Number four, for anybody who's an instructor, what changes do we need to make dive training safe? And then very important for someone like myself, and maybe for some of you in the club, when can someone return to diving after contracting the disease? So number one, can the virus be spread underwater? We don't know, to be honest with you. But the data we have to look back at the SARS-CoV-1 virus, which was the SARS virus back in 2002, 2003. That disease actually was harder to inactivate, harder to kill than the than the CoV-2. So things that work for CoV-1 will probably work for CoV-2. Chlorinated and bromated pools and hot tubs completely inactivate the virus. So if you're doing training or you're in a swimming pool and you're separated from one another, there's no real chance of getting the disease from the chlorinated pool. However, of course, if you're standing close to one another, talking to each other in the pool, it can still be transmitted in that way. The CoV-1 virus was found to be infectious for long periods of time in surface water, like lakes and rivers. And the data for CoV-2 looks to be the same. So standing water like in a lake or even moving water in a river could theoretically be infectious at the surface. Now, obviously, we don't spend a lot of time at the surface, and when we're at the surface, we have a mask over our face and a regulator in our mouth, so the likelihood should be very, very low. We have no data on salt water, but it would be extremely unlikely to get infected from salt water given just the dilutional effect of the large ocean. It'd be very, very unlikely to get infected from that, but we don't have a lot of firm data. How about disinfecting our gear? Now, this is a situation that we probably should have dealt with a long time ago. Most people don't disinfect their gear. They rinse it, right? You try to get the salt crystals off, so you basically dunk your gear. You may be dunking your gear where everybody else is dunking their gear. But really, we should be only using disinfectants that are listed on what's called the EPA List N. The EPA List N will give you a whole list of disinfectants, what agents they will, what viruses and what other bacteria they will kill, what concentration you need to have, and what contact time you need to have to accomplish that. I've gone through this. It's a very clunky website. It's not real user-friendly, but common things that do inactivate the COVID-19 virus. There's two forms of maticide. You can get these off Amazon, Maticide 1 and Maticide FD. There's a whole bunch of different types of simple green products, but the two simple green products that have been tested and been shown to kill the virus are Simple Green D-Pro 5, which is the bottle there, and Simple Green Clean Finish, which is a spray bottle. In the rebreather world, a lot of people use Virkon S, which is on the list. Unfortunately, the other agent that we use in rebreather cleaning all the time is called Stearamine. That is not on the list N, unfortunately. That doesn't mean it doesn't work. It just means it hasn't been tested. But so if it's your own gear and you're rinsing it off yourself just for your use, it's probably not a big deal. But if you're a dive charter or you are an instructor or a dive shop and you're trying to keep gear disinfected for students or people or customers and so forth, I strongly think we should be using something on this approved EPA List N to make sure we're doing everything we can for our customers and for our students. And these are the most common products. The problem with all of these products is they're not very environmentally friendly. They're very toxic. So the people at, let me go, here's one more before that slide. If you don't want to use those, you can use bleach. Bleach is obviously very toxic. You would use 1/3 of a cup of bleach in 1 gallon of water and let it sit there for a minute, and then you'd have to rinse everything and let it dry. The other issue with gear, especially if you're doing rental gear or something, is you don't want to reinfect it. In other words, if you've got some guy at the shop and you've disinfected all the gear, and then he's sick and he's not wearing a mask and he's coughing on his hand and picking up the gear and hanging it back up, you just reinfected it. So you need to be careful all the way through the whole process. What I was mentioning before, like all these things are environmentally toxic, but the developed in conjunction with Fourth Element and with the Diver Medic as a new product. I've got some on the way to me that the Fourth Element is sitting, but I haven't received it yet. It's coming from England. It's an environmentally friendly powder-based, which is a very powerful oxidative product, which has been tested against other coronaviruses, but not COVID-19 yet. It just got announced in June of this year. We put 1 tablespoon in a gallon of water, and it hopefully will be very effective. They're in the process of testing it against COVID-19 now, but at least that would be an environmentally friendly alternative to the other agents I just talked about. Okay, so how do we stay through Zoom diving? We've all now been kind of doing this for a couple of months, and people have some ideas. A lot of the things like we're doing right now with the Zoom conferences, there's a lot of people doing a lot more online training and online presentations. We'd want to have fewer students in the classroom and the pool. And then also from a dive shop standpoint, we need to disinfect everything touched by the customers. I mean, everybody, if you don't ever buy a mask without trying it on. So all these people are coming in, trying masks on, putting them back on the shelf. We have to some way to make sure anytime someone touches a piece of equipment in a dive shop that it gets disinfected before it's put back to the next customer. We had a little discussion before the meeting started about dive charters and who feels comfortable with what. What's currently happening, at least in the charters that I've been on, is face masks, not dive masks. Face masks are required for all crew and all guests at all times, that you don't have a dive mask on your face. They're putting fewer dive boats. The limit in South Florida was 8. Now what they're doing up in the West Palm area in Palm Beach County is you have to maintain 6 feet of distance on the boat between groups. So if there's 2 different families of 4, for argument's sake, that family of 4 could all be together, and the other family of 4 could all be together, but the distance between them would need to be at least 6 feet on the boat. That gets the boats that would normally be holding maybe in the mid-20s of people to maybe 12 or 14. Mask buckets have gone away. Obviously, you're not going to be rinsing your mask with everybody else rinsing their mask on dive boats. Those have pretty much gone away. Divers are usually required to wear their masks and regulators in their mouth from the time they get out of their spot to the time they hit the water. And also are, as we should anyway, keep their regulators in their mouth, masks on their face as they get out of the water, and then take that all the way back to their spot on the dive boat. And the other thing is for things like snacks and drinks and so forth, a lot of the dive operators are saying they still have those on board, but are asking clients and customers not to reach into the cooler and grab drinks or use the cooler of water or grab the snacks, and just ask one of the dive masters. They then disinfect their hands. They get something, take it to you and disinfect their hands and take something to someone else and so forth. So trying to do what we can to make things as safe as we possibly can. The other thing I'd like to mention when we're talking about dive charters is, I know we all know this, but just to kind of reinforce it, most of the dive masters and so forth don't get paid very well. They make their money on tips. Right now, there are not full boats going out. There are 8 people on a boat that normally held 20-something, or maybe there's 10 or 11. So if you have the means, it would be a very good idea to tip heavy here while we're in this. If you have the financial means to do that, we want to keep the dive shops alive. We want to keep the dive charters alive so that we can all get through this together as an industry and enjoy the sport that we all love. Along those lines, I don't know who the people in the audience are, so I thought I'd throw this in there. If anybody owns a dive shop or works with a dive shop, DEMA has come out with some ways to help dive retailers. They have 3 different phases of this: relaunching dive retail, phase 1, 2, and 3, and this is available on the DEMA website. If anybody either has friends in the dive industry or if the dive industry themselves, to kind of help with businesses and keeping them afloat during this difficult time. As far as dive training, really the only real issue from dive training is the out-of-air drill. Because normally, obviously, you will pass either the primary or alternate to someone else and they then put that in their mouth. That's not happening in the era of COVID-19. You could say, well, we can still do that in the pool, but we won't do it in the open water that way. Well, the problem with that, of course, is with training, you want to do things in the open water the same way you did them in confined water, just to make it kind of muscle memory. So a lot of the agencies have changed how they do air sharing in their training over the last few months. The first one that came out with that was RAID. This is kind of how they do it. So currently what they're doing is have the donor pass their primary or their alternate to an out-of-air diver, who then holds that in their hand, and they switch to their own alternate second stage. So that way you've got still the memory of holding a regulator in your hand and breathing off a different regulator, but it's still your own regulator, not someone else's. That is not ideal, but it's probably one of the best ways we have to do training, at least till we get through this pandemic. And I've seen some dive stores that have actually taken the mouthpieces off rental gear so that students and customers buy or break their own mouthpieces. Now, of course, that's probably more perception than reality, because a regulator has more than just a mouthpiece, so you really wouldn't be changing a whole lot of that. But again, that's what I've seen some people do. All right, so that's pretty much everything except the main thing we want to talk about, which is, what about if you get COVID-19? Okay, so let's say you're like me, you've had the illness now, and you want to get back to diving. What does that look like, and what is the risks and so forth? Right now, we don't have a lot of real data to make firm recommendations. The problem is, a lot of you may have seen this, but back in April, Dr. Hartig, who I'm sure is a wonderful physician and very well-meaning, scared the crap out of everybody in the dive industry. He published his experience in a magazine called Wet Notes, which is a diving publication in Germany. And somehow that got posted on Facebook, and it went nuts. So that people like myself who work with, I'm a volunteer consultant, but work with Dan, got just inundated with questions. What he did was, he apparently was a physician in Austria who had dealt with a large number of COVID-19 patients. Says that he had looked at, taking care of dozens, quote unquote, dozens of divers. 6 of these non-hospitalized divers out of, quote, dozens, he looked at. All of these 6 divers felt well 6 weeks after their symptoms had gone away. Then he did some tests on them. They found that 2 of the 6 showed hypoxia, meaning they dropped their oxygen levels when they exercised. 2 more developed exercise-induced reactive airway disease, which would be like exercise-induced asthma. And 4 showed what he called, quote, impressive, unquote, lung changes on CAT scans, like those CAT scans I showed you earlier in the presentation. And unfortunately, and I doubt he really meant this to come out this way, but as it was translated into English and posted on Facebook, it was worded as that these divers had irreversible lung damage and they would never be able to dive again. And that scared the crap out of everybody. The problem with that from a medical standpoint is you can't make that statement. I mean, you've got a total of 6 divers. This was not a controlled, randomized, or any kind of study. It was just 6 people. It's an anecdote, basically, that had bad findings. But we don't know how that correlates with other people. And we also know that lots of times you can have lung illnesses that can take weeks or months to get better, but they do get better. So the fact that at 6 weeks these people still had some issues does not mean that they necessarily would be never able to be diving again. So when this came out, we had to try and look back and see, well, what data do we have? And we do have some data from the SARS virus, again, the SARS-CoV-1 virus. So we'll look at that. This publication from Dr. Hartig became so widespread that the Undersea Hyperbaric Medical Society had to actually put a position paper on their website saying, and this is verbatim from their website, at the present time, we do not have sufficient data to support or refute the proclamations made by the case series from Dr. Hartig. The list of potential variables related to how this disease manifests, its clinical course, and in long-term prognosis is lengthy and may include factors such as underlying medical conditions, age, disease severity, and secondary complications. Case reports like the one he reported suffer from multiple design weaknesses to include a lack of controls, lack of randomization, and this makes any conclusions that we'd want to generalize to a larger population suspect. And then finally he said, with these findings are indeed, while these findings are indeed disquieting, it will take time before the potential impact on individual health and any lasting effects are captured in peer-reviewed literature. So basically said, yes, it's interesting, but please don't don't get overly concerned. It's just kind of interesting and means we need to look further. So what data do we have? So we do have some data on the CoV-1 virus, the SARS virus from back in 2002, 2003. This was a study that was reported in the European Respiratory Journal in 2004. That's the reference if anybody wants it. They looked at 46 survivors of SARS 3 months after hospital discharge. So these are people who had been sick enough to be in the hospital and then looked at 3 months after they had recovered. They found that 50% of people had absolutely no abnormalities whatsoever, which of course means that 50% did. The 50% people who did have abnormal findings on their pulmonary function test, that's what those little acronyms are down there, FVC, FEV1, and so forth. Those are lung things that we look at on pulmonary function tests. You see a lot of them did have some abnormal findings, but almost all of these were mild except in one case. So basically out of 46 people, 23 people had no abnormalities whatsoever, and then 22 of the 23 remaining people had very mild abnormalities, had very mild abnormalities for one person. So only 1 out of 46, which is going to be a little bit over 2%, had any kind of significant problems 3 months after hospital discharge. So we're hoping that the SARS-CoV-2 or COVID-19 behaves like this, but we won't know that yet. The Belgian Society for Diving and Hyperbaric Medicine, and I'll be honest with you, I did not even know there was a Belgian Society for Diving and Hyperbaric Medicine until April, came out with recommendations based on general consensus. This is based on no data. This is based on a bunch of hyperbaric doctors sitting around who are experts in the field and saying, we want to be conservative. What should we recommend? And this is what recommendations are out there at the moment. There are no firm data yet from recommendations from DAN or from the Undersea Hyperbaric Medical Society. But from Belgium, this is what they have recommended. They say that divers who've had COVID-19 should wait a minimum of 2 months, preferably 3, before resuming diving activities. Divers who test positive but are asymptomatic, they recommend waiting 1 month. They say, since we don't know how this affects the lungs, there may be an increased risk of pulmonary burial trauma. So that if the people have been hospitalized, they've been sick enough with their lung disease to require hospitalization, they should wait 3 months and then undergo some lung testing with pulmonary function tests and a CAT scan of their lung. Again, because people who have been sick enough to be hospitalized have an incidence of cardiac involvement, again, they recommend waiting 3 months for those people, and then those people should undergo exercise stress testing and echocardiography, which is an ultrasound of their heart. There is the other issue of not knowing how the body will react from a pulmonary oxygen toxicity standpoint once the lungs have been damaged. So the recommendation is to avoid breathing prolonged hyperoxic gas in people who've been hospitalized. This is mainly affects people who dive rebreathers, where you maintain a PO2 of 1.2 or 1.3 for a very long period of time. Simple nitrox is not an issue there. And then also, since we don't know how effective the lungs would be at on-gassing and off-gassing, once they've had this illness, the recommendation is the divers should stay well within no decompression limits just from a safety standpoint. And that's the data that we have recommended out there. So what are my biases? So this is how I've kind of put all the data together. So when can someone safely return to diving? This is obviously my bias as of August of 2020. My first recommendation is that everyone should get their diving information and recommendations from things like DAN, Undersea Hyperbaric Medical Society, or South Pacific Underwater Medical Society, and not from social media like Facebook. Okay, so that probably goes for lots of things. Don't get your knowledge or your opinions from Facebook, but get it from experts. This is not going to be a one-size-fits-all scenario, just like it is with any other disease. We all know there are diabetics who should never dive. We also know there's lots of diabetics who dive very safely. We know people with asthma who should never dive. There are also people with asthma who dive safely. There are people who've had bypass surgery or coronary stents who probably should never dive. There are lots of people who've had those who dive very safely. This is going to be the same thing. There's going to be some people who have a very severe case of this disease, who have been hospitalized a long time, had very bad lung damage, and unfortunately that very, very small percentage of people may not be able to dive again. The vast majority of people either have no symptoms at all or have very minor symptoms. Those people probably have no restrictions to them and get back to diving right away. And then there'll be an intermediate group who will probably need to be out of the water for a period of time until they have been fully evaluated and returned back to normal. So because of the fact that signs and symptoms of this disease are highly variable. So personal opinion is the first thing is you shouldn't even consider returning to diving until your normal level of fitness has been achieved. Now, this, of course, assumes that we have an exercise regimen before the illness. I tell people, I've told people for years that you do not scuba dive to get in shape. You should get in shape to scuba dive. So all of us should have some idea of what our level of exercise fitness is. And if you are unfortunate and contract this disease, the first thing you should do is make sure you're back to the level of fitness, like I told you I did with the rowing machine after I got sick. Then, once you feel you're back to your normal level of fitness, divers should then be evaluated by a physician who's knowledgeable in diving medicine before returning to diving. If you were somebody who was jogging 5 miles a day and you got the illness and you're now recovered and you're back to jogging 5 miles a day, you can probably just go jump back in the water. That's no problem. But people who've been hospitalized, you need a diving physician to kind of get a feel for what illness, what organ systems were involved, what testing may need to be done. Do they need lung function testing and CAT scans? Do they need exercise stress testing and echoes for heart involvement? That sort of thing before clearing them to returning to diving. So I think that's the best approach. I'll also let you know that the new diver medical, I don't know if anybody's taken a class recently, but whenever you take a diving class, you have to fill out the little medical. This thing's been around since 1988. They've just changed that. They've just updated it. It's a much better form. It now only has 10 questions. If those 10s are all no's, you're good to go. If any of them are yes, there's some other little questions to go on with that. But on question number 1 of that new diver medical, which just came out in the last month or two, it talks about having lung disease and actually specifically says, have you had COVID-19? So currently anybody with COVID-19 is going to have to check yes on that form, and all those people have to require some evaluation by a physician before returning to diving. So divers should be evaluated, like I mentioned, by a physician knowledgeable in diving before returning to diving. And this is the best approach I think we have at the moment while we're awaiting further data, not from case reports, but from well-designed studies published in not dive magazines, but peer-reviewed medical journals. And if anybody out there has had COVID-19 or knows someone who's had COVID-19, Dan is organizing a study to try and follow these divers, to try and give us some information. So if you are interested or know someone who's had this that would be interested in helping Dan gather some data, you can email them directly at medic@dan.org. So in conclusion, COVID-19, which is a coronavirus, just like 10 to 30% of all of our common colds, is a serious illness with a mortality rate that's about 10-fold that of seasonal flu. Most people have no or very mild symptoms, but a small percentage of people can get very, very sick and can die. This disease is spread by respiratory droplets. So to decrease the spread of the disease is why we need to do things like social distancing and wear masks. Do masks completely eliminate things? Absolutely not. However, you can markedly decrease transmission by having some form of a barrier. And then the elderly and the high-risk patients should shelter in place as much as possible, because if they do get this illness, their mortality rates are very, very high. And then as we have found, that as restrictions are lifted, there will be an increase in the number of cases. So that's to be expected. We're still just trying not to overwhelm the medical system. That was the whole reason for this flattening the curve kind of concept. So individual divers, dive shops, dive charters, training agencies, etc., all need to adapt and follow guidelines on disinfecting items, social distancing, etc. And returning to diving after infection should be possible for almost all divers. They need to be asymptomatic and have returned to their baseline level of fitness. And then they should all be evaluated by a physician knowledgeable in diving medicine to decide if further testing is needed before they return to diving. And I think that should be everything. I'm open to take any and all questions.